last lecture, that is on how best to tackle the second wave of COVID-19 in India as well as in Kerala. For this, I would like to invite Dr. Rajeev Jayadevan, who does not require any introduction to any academic audience in India, because even though he's a gastroenterologist by training, he's now into COVID-19 for the last 1.5 years. And the best way to follow any recent research in COVID-19 is to keep track of his Twitter handle. So I'd like to invite Dr. Rajeev for the last lecture.
Thank you for the introduction and thank you for the invitation. So the time is 10 minutes. I'm just starting my stopwatch now. I'll stop in 10 minutes. The topic that has been given to me is how best India can tide over the situation. So let me start with some good news, because we all need some good news, because India is going through a bad phase now. But all of us have tracked the pandemic over the year, and there were several uncertainties and anxieties I had personally had last year before the pandemic hit India. So many of those anxieties have been allayed, and I'll explain what those anxieties were and how they've been allayed. First, my main concern was this was a coronavirus, and they're well known for reinfections. So that was my prime concern. And fortunately, we now know that reinfections are rare. They are, in fact, rare. The second is that we know that if you wear good protective equipment, it saves your life. How do we know that? Because I had personally been involved in several studies involving deaths of healthcare workers back from April onwards last year, and had, along with the help of all the members in IMA and with good people like Nisha and Hari abroad, we had circulated useful information for our healthcare workers, all the way from nurses to doctors back from April, well before the pandemic hit us last year. And all the doctors in Kerala in particular were well aware of our writings. We had continuously bombarded them with our material. We had talked about ventilation. We had talked about open air settings. We had talked about transmission in canteens, for example, when you take off the mask and so on. If data is to be shown here, you might have seen my work on deaths of doctors in India. In India, on record, there are about 782 doctor deaths in India. That's so tragic, because these people lost their life in the line of duty. And there are several more, I'm sure, that went undocumented. In Kerala, there have been 15. So I'll just leave those numbers in front of you, and you can make any inference out of it. I follow these numbers very closely. The third good news is that we know that vaccines work. So that's a very, very fantastic good news. Sometimes we forget that because imagine a scenario where vaccines did not work. We know on the ground that vaccines work. And on the ground, I mean, I network with doctors, particularly in Kerala and also from the rest of India. And everywhere we are having information pouring in that among all the hospitalized people, among all the vaccinated people, hospitalization is almost non-existent. So that's very encouraging information. And the fourth encouraging information is, again, I wanted to start with some good news, is that with all the variants that are happening, with all these horrible sounding names for mutants that are mainly given by non-medical people, none of them are actually killing people more than other variants. So the original variant, the original clade, in fact, there's one paper out that basically says that the first clade that came out of Wuhan may have had a slightly higher mortality compared to its contemporaries. I'm not talking about on a timeline. In the beginning, the first clade that came out had greater mortality, and even after correcting for improvement in treatment modalities, that difference remained. So there is some feeble evidence that the virus may be losing its virulence. But as Dr. Anish correctly said, and we have said a million times on all sorts of forums, it is really not the per person mortality. It's a total number. It's a denominator that determines the tragedy or the scale of the tragedy. All right, so that's number 4. And number 5 is that we know that, as Dr. Hari correctly said, we know that even if you don't vaccinate people, you can control the pandemic. So we know that there are methods which are old-fashioned: test, isolate, and treat. And that whatever Dr. Tedros said in the beginning of the pandemic from WHO, that's what he kept saying: test, isolate, and treat. You know what? That actually works, and we have some nations that taught us that. So those are some of the main good points that I want to emphasize, and these. If any of these had been the opposite, we would have been in much more trouble than we would be now. So Dr. Vinay Kumar, in his initial address, he talked about lack of data. That is true. India suffers from lack of quality data. And while there's one way is to sit and lament about it and complain about why people are not publishing, we chose, some of us who work in academics here, we chose the alternative. We said, let's generate our own. And there are two ways to generate your own data. One is to do your own studies, and second is to network with people of credibility. So I've used the last 1 year to network with incredible people who are very, very smart and honest and diligent, who work across the country. And we have shared information, and my Twitter handle is one example of sharing good information. Everything I read, I summarize and put it on Twitter. It is out there for people to read and understand. And Nisha and I work quite closely on Twitter. She is very active on Twitter as well. So you can use the handle. I've put out over 4,600 tweets in a year, exclusively relating to the pandemic. There is no humor or non-pandemic related issues there. So that handle has been used by the media. Sometimes they quote you directly from Twitter. And I'll give you one example of how we use local data. Every Tuesday in Ernakulam, under our Cochin IMA and our doctors in KGMO and all that, we don't really talk about organizations here, but basically it started from here. We network with doctors all around the area. We sometimes invite people from outside the district. For the last 1 year, every Tuesday we meet up on Zoom and we discuss the cases. It's like a coffee table meeting. I've chaired the academic meetings in my own hospital, and I keep it non-confrontational all the time. It's like a coffee table discussion. And I follow the same format here, so people don't feel intimidated. They can come up with silly ideas. Sometimes the silliest ideas are the best. So not only does this update myself and all the people who attend, we are also able to generate good data. I'll give you one example. In Hindu, in January this year, we put out an article. That's myself, I think Professor Suma and Dr. Rajalakshmi. Three of us wrote separately in that article, authored by C. Maya of Hindu. We wrote that the ICU beds in Ernakulam district are getting full. We wrote that we have information that 70% of our COVID ICU beds are full at this point, and that number was increasing by the week. And so this warning was sent out as a press release and also was taken up by the Hindu. The government looked at it very carefully, and they responded favorably. They took, I think, some high-level announcements came and some measures were put in, and our ICU occupancy came down from 70% to 30%. Now, there are several ways to measure the temperature of the pandemic in a population or the severity. The way that we can do it is, if there are X number of ICU beds in a community, it's really a DA in American lingo. You just have to see how many people are there in your ICU beds to find out. It's like looking under a large tree and finding dried leaves. And if you only look at the ground and look at the dried leaves, you can estimate how big the tree is simply by looking at the dried leaves. So in other words, the more the number of ICU admissions in a region, you know that there's greater penetration of pandemic in the community. So we sent out the warning in January. We sent out another major warning on the 13th of April. We followed it up with another one on 20th of April, and look where we are now. So this just shows that if you collaborate with people, you can compensate for the lack of medical literature otherwise. What India can do forward, I think we need to focus on some real core areas, and I'll highlight what they are. One, we need to realize that this pandemic is an indoor disease primarily. There are 2,400 super spreading events in the world that are documented, many of which are from India, and all of them are indoor events. Some of them are indoor-outdoor mixed, and there's one major event that is it's called the Road Safety Series that Sachin Tendulkar and Brian Lara played in Chhattisgarh, and that was another super spreading event that's not been documented. So that is perhaps one of the largest outdoor super spreading events when they played. I watched that match on my mobile phone. So that is one. But most of the others, they're all indoor. So we need to focus on indoor strategies, and we need to mass vaccinate. India has headed the world in the total number of doses given a day, but given our capacity to vaccinate the whole country, I don't think we've done well enough. I think we could have vaccinated a lot more people than we had in the last 4 months. So I think that is something we should really, really ramp up. We should watch for data from smaller nations. That's what I'm really, really looking forward to. Gibraltar, Israel, and UAE are 3 nations that are on my radar. I'm constantly on the phone I'm harassing my friend from UAE. Please give me data. Please tell me what you're looking at. Please tell me what you're finding in your ICUs. I'll tell you what some unpublished and unconfirmed anecdotal observations. The UAE has mainly inactivated whole virus vaccine. And around the time of vaccination, the so-called the Pelsman Effect took place, and there were a lot of people that came in positive after the first dose. That was partly because they crowded at the vaccination centers, like what happened in India, and also because they became less careful. So that is something that we noticed. And there are plenty of diseases that actually came in after first vaccination, but very, very few deaths, very, very few severe diseases after second vaccine. My point is, we may soon find that inactivated virus vaccines are very good, but only if you take 2 doses. And we are getting signals from all around the world that maybe 1 dose of a vector vaccine might be enough. I know that's a provocative statement to make, but I think we should watch that space very carefully. Again, these are not evidence-based, but I think we should really throw out these statements out to the front. I'll throw out another very provocative statement, again, which is mostly based on evidence. I've seen people hanging around in full spacesuit PPEs. I don't think it is necessary at all. I think we should stop using full PPE and just have people wearing proper N95 masks, which are well-fitting masks. And I think that should be the universal thing, except in very, very, very selected settings, which are profoundly AGPs. If there are AGPs, yes, definitely yes, for a full PPE. But I think we must revise the protocols. I think it'll make our healthcare workers much happier. And B, I think it's a lot easier. It's a lot easier to handle, and we can cut our healthcare costs down quite a bit. Another way to cut the healthcare costs down is to reduce this silly polypharmacy that we see universally happening in India. I'm ashamed to say that the status of evidence-based medicine in this country is so pathetic that people, healthcare providers and patients are pushing to write more and more medicines. I don't see why. Nisha and I have exchanged so much about this. We write all kinds of wrong medicines. I think that's completely wrong. I think that must really, really stop. And I've lobbied severely for it. Sometimes I find myself as a lone warrior, but I think as collective bodies, I think we should really write and speak out in public that none of these medicines are helpful to our patients. So I've reached about 12 minutes. There are a few more things that I wanted to share. We must have better genomic studies. More than 100 that we are doing per district now. It's better than nothing, but that's really not good enough for a very large country. We're doing 100 samples a month per district. That really may not tell us where we are headed. And last, I will stop by saying the schools. I do not know what role the schools will play. As much as we want schools to reopen, we know Indian schools are different from Western schools. There is no social distancing. Children are very, very physical. They yell a lot, and when they talk, we know the virus spreads. So that is one big question mark. I don't have an answer there. So that is something we must watch out for. And I think I'll stop now because there's really not much of, there is not much time for some of the remaining points. Maybe I can cover those during question time. Thank you for your time.
Aravind, you are mute.
Dr. Aravind,
sorry. Thank you, Dr. Rajeev, for the excellent session as usual. And you actually highlighted the main points that we should, the state as well as the center should look at and to implement in future. And since we are running short of time, we'll straight away go to the discussion part of it. There are certain, the questions have come in the chat box. I will take it one by one.
Means at least a small proportion is going to die.
contraindication for pregnancy and lactation and during IV oxygenation, pregnancy as well as on that. And transfusion.
So is there yes. Treatment.
This is Harry. To the first wait 12 weeks.
I just wanted to add one more treatment
of the tune of exactly as
it is highly unlikely that you're going to get any benefit from the vaccination.
Yeah.
Arvind, there is a paper from Lancet that I mentioned yesterday. Exactly as Dr. Hari said, for a single dose, it doesn't really make much of a difference in a solid tumor or even for hematological malignancy of the tune of around 16 to 38%. 38% response after a single dose. So they really need 2 doses. But with 2 doses, the good news is that people with solid tumors did about 95%. They used the mRNA Pfizer vaccine, and they didn't really have that many numbers of the hematological patients. So they recorded a 60% response after 2 doses. The bottom line is single dose might not protect them, exactly as Dr. Hari said.
Thank you.
Other hospitals also, government that is being done by the district administration, and that is being carried out. We should make sure that there are to come
protect them, exactly as Dr. Hari said.
Thank you. Actually, Sima madam was asking.
It is not a question. I was to comment on what Rajeev Jayadevan was saying about the fire and safety. Actually, what is happening right now is that that has been taken care of, and along with the COVID management team, the fire and safety people are also there. If in a district, if they are starting any CFLTC or second line treatment centers, initially they make sure that there are
for vaccination. Is there any
say something?
Sure, sir.
Yeah, you asked me to talk about how best India can tide over. I think you may have gotten a message from me today. I don't know if I sent it to you, but one of the concerns I have is fire. Fire is a problem with increasing use of oxygen cylinders. Many more hospitals are going to catch fire. I'm a fire safety trainer, hence the interest. See, fire is something many people take lightly. And remember that oxygen cylinders, when there's a high turnover, there are a lot of points where oxygen cylinders can catch fire by simple preventable mistakes. See, for example, the type of grease they use, the type of the way they open the valve, and so on. If they hire a temporary laborer, a temporary worker in a hospital to in an emergency to use oxygen cylinders, I can see fires happening even in Kerala. So I think we should really issue a strong advisory to all hospitals to train all the people so that only the most trained people will handle the oxygen cylinders. Even otherwise, hospitals are at risk of fires, and people in ICU are, I don't want to say the word, they are so helpless they can't be moved. It's almost impossible to move a patient on a ventilator, literally. So that is something that we must anticipate and take evasive action against. Thank you.
It's actually a very valid point. Yes, sir.
I have a comment and I have a question. Comment is regarding that.
So unfortunately, after
for vaccination. No, how do we schedule? Arvind,
Madam, by the Blood Transfusion Society of India, the second question is totally up center on. We're having
indication doing it, all the a little bit more protective. Even so, only about 30%
who come to us surgery
because
sure.
this is Harry.
This vaccinatory treatment.
There's one
I'll clarify that. Arvind, I'll clarify that.
With this on a chemotherapy timing in
kind of
course, it doesn't really make much of a difference in a solid tumor or in numbers.
Safety people are also there. If in a district, if they are starting any CFLTC or should be there, then only they'll allow you to start or make the patient put there. So similarly, even in hospitals, other hospitals also, government that is being done by the district administration, and that is being carried out in all the hospital, and to look for this one, because that we have a lot of oxygen coming into the hospitals, and sometimes it is being used like anything. So they have started taking care of that. That is a good thing to have.
Thank you, Doctor. Thank you.
Plasma.
Can you donate plasma?
Why don't we give test doses for, no, not practice for vaccination?
Dr. Hari or Dr. Rajeev?
The chance of getting an allergic reaction in a vaccine is about 1 in 250 to 500,000 severe allergic reaction. So the if you calculate the labor involved, the number of test doses you have to give, and the number of extra steps that the personnel have to administer, and the amount of discomfort the patient has, does not justify the potential risk of adverse outcome.
So in cases of people who suspect that they could have allergy, is it possible to give a test dose for them?
In fact, if you look at the list of people who can't take the vaccine on account of allergy, it is almost zero. Even if the patient had an anaphylaxis to another vaccine, it does not apply to this vaccine because the components are completely different. So everything depends on the components. The only exception here is that if the anaphylaxis occurred to an unknown agent, in which case the treating doctor has to take the call.
Polycythemia should definitely take.
Please.
2 times, my antibody was showing above 150. If I have, this will be produced. In spite of all these things, is it necessary to have the vaccine?
Let me take the call. All right, I'll take the question. So you ought to have you ought to have at least 1 dose of vaccine. The reason is your natural infection will act as the priming step, and your vaccine will provide the booster dose. Now, in the priming phase, your body will generate antibodies, and as Dr. Hari showed in his slides, your T helper cells are just ready to go. When they get exposed to the vaccine, they're going to amplify their outcome, and you're going to create a lot more memory cells. And memory cells, they go and lodge themselves in your lymphoid tissue. It is the ones that home into your lymphoid tissue that will protect you in the long term, and not the other ones. So you want to create the maximum number of memory cells, and your best bet is to get 1 more dose of vaccine after 2 or 3 months following the COVID infection.
Is it necessary to take any particular vaccine, sir? Because I am in Dubai, and we are all provided by the Sinopharm, the Chinese vaccine.
They're all the same. Go ahead.
Okay, sir. Thank you. Thank you very much.
Dr. Aravind.
Actually,
Hari, a lot of the long-term, Hari, are you here?
Go ahead, Rajeev.
Yeah, go ahead. Okay, Hari. Okay, the question is, do I need the booster? Now, we know that a lot of the long-term protection from vaccines come from what is called long-term memory. Either it can be B-cell memory or T-cell memory. Your T-cell memory will help generate your natural either cytotoxic T cells or your CD4 cells as a result of the memory, and your B memory cells will help generate antibodies. So if you want to whether you need a booster or not, if you really ask the question to someone like Hari, who's really renowned in the field, if you take 100 people like Hari, 18 of them will say you got to wait 2 years. And this is another data, and about 80% of them will say maybe in a year, but that is expert opinion. Okay, that's level 5 evidence. But if to directly answer your question, I'll say this: until we know that vaccine immunity will wane, and there are a substantial amount of infections that are occurring at the tail phase of vaccination, I do not think we are really going to support a booster dose. I know people are talking about it. Obviously, it's important to talk about it, but whether they're necessary or not, it depends on how these vaccinated populations do over an extended period of time. Dr. Arvind.
That's totally true. Just if I may add a tiny point, is that in the future, I think if the variants establish themselves, then we might need a slightly modified version of the vaccine in the future. But at this point, it is not very clear that the immunity wanes or to what extent it wanes. And if such waning happens, how the pandemic will play out. Totally agree with Rajeev.
And to add to Hari's point about that, I know it's late, but you want to look at a paper by Shane Crotty and Alessandro Getty from La Jolla Institute in California. They've done pioneering work on T cells, but very briefly, in one sentence, I'll say this: T cells work on an average of 52 to 24 epitopes, and your variants are having only about 3 or 4 different epitopes altered. So chances are there's a good chance that your T cells will, as Shane Crotty says, T cells do the heavy lifting when it comes to your immune response. So even if your neutralizing antibodies fail and the virus gets into your body, what matters is whether you get severe disease, and it is really your T cell response that determines whether you get severe disease or not. And there's a good chance, I'm saying there's a very good chance your T cells might not really have a problem with these variants. So we'll end on that optimistic note.
Sure, sir. Sir,
I just want to add
please.
a point.
One more. Actually, yes.
Months or so.
Been some testing like.
Is it with me? Please.
Knows the, but you can. What is that?
We don't have
That you should not interchange.
A question. Either
also Covishield.
1 or 2 cases.
500 malignancies will occur in the.
It's basically coincidental, sir.
Yeah,
Coincidental.
Might be a background rate.
Maybe.
Yeah, if you take 10 million people and follow them over 2 months, about 6,500 malignancies will occur in that cohort in 2 months. 10 million people, 2 months, 6,500 malignancies. This is without vaccination. This is the background rate.
Yeah, Dr. Aravind.
Option that is going to be relevant in.
I want to ask Dr.
Rest of the world, we're going to have a continuing.
See in India, like
recently developed vaccine.
my question to Dr. Rajeev, please.
Please go ahead, madam.
Please, madam.
Yeah, I want to ask Dr. Rajeev, what do you see in India, like when we will have the peak and when this will end actually?
Well, India is going to have, just like the rest of the world, we're going to have a continuing series of waves that will come. This is the reality. It will come. These waves, so far, if you look at history, they've occurred about 3 times a year. The average duration of a wave is about 3.5 months, but that doesn't mean that each wave has to stop at 3.5 months, and the gap is 3.5 months in between. India's future will largely depend on 2 things. One, how much of our population can we successfully vaccinate, preferably with some of the newer generation vaccines, as Dr. Anish said, to account for some of the newer genetic variation. And secondly, we will really have to come up with mass treatment facilities, which we don't have the time in this session to go into that. Things like, say, oxygen and things like steroids, and without having to use our large-scale hospitals, there may be an alternative. So there are so many other customizations to occur in Indian treatment scenario for a very densely populated country. But the most important thing is to realize that this is not a single-step pandemic. It will keep coming, and as the time goes on, the number of people who die from each wave will become less and less, and that is what we hope for.
I will only speak during the last October. That it will be pattern of, you will see more. Another event of death.
Concentrators for.
That is how severe COVID guidelines and just
was my
what a concentrator does is it.
Was my concern.
Dr. Arvind, can I add to that? Can I add to the
definitely, sir.
Yes. See, for the audience, I'll just explain in one sentence what a concentrator means. Basically, what a concentrator does is it takes room air, it condenses all the nitrogen out, it filters all the nitrogen out, so the air that's coming out has less nitrogen. So if you reduce the concentration of nitrogen in air, then naturally, by default, the concentration of oxygen will be higher. That's why they call it oxygen concentrator. Now, there is one paper that's on my Twitter. I think I did that a few days ago. Basically, it's a paper from one trick I do is I look back at papers long time before the pandemic, so they're not biased from the pandemic. So this paper was from many years ago, say 5 or 6 years ago, when they looked at 7 different concentrators from reputed makers, 7 of them. They tried them under 2 different conditions. One is with a relative humidity of 95%, and the other was a relative humidity of 50%. Now, you know that at least in parts of South India, the relative humidity is about 85 to 95%. And in fact, today it was 100%, I think. So they found that 6 out of the 7 did not work in high humidity conditions. They failed to deliver. Only 1 from reputed, branded, certified equipment actually delivered. So as Dr. Arvind said, they only deliver like a very feeble amount of oxygen, and they're horrendously expensive. 60,000 to 1 lakh is the price that is listed on Amazon, and they're out of stock.
For about 20